Yeah, welcome to Decoding CTO case 43. Today I am bringing a case of ambiguous cap mid LED CTO. I am Dr. Sharath Reddy, consultant interventional cardiologist, Medicover Hospitals, Hyderabad. So this case is 74-year-old male, status primary PCI to right coronary artery for acute ST elevation in femoral MI. During that time, he was found to have a CTO of LAD, which was kept for subsequent elective intervention. So his rhythm was normal and he had good LVRV function. This case was done in Jindal Heart Care in Bathinda. So this was the dual angiography which you can see. So there is a mid-LED CTO after first diagonal. You can see clearly there are three branches coming out of LED at the site of total occlusion, chronic total occlusion, and you can also see a bifurcation after the total occlusion. There is another diagonal, that is D2, and we can clearly see a stent in right coronary artery, so which is there from ostium. Yeah, so coming to JCTO score, come to the proximal cap. If you see here, there is a diagonal, there is one septal, and also there is another branch which is going straight, appeared to be a septal or bar LED. So this is making your cap is ambiguous and with multiple side branches at the proximal cap. That even makes your imaging more difficult, much more difficult to understand and target your proximal cap. So same thing here. So it's an ambiguous proximal cap, and the length looks like maybe more than 20 millimeters, and then there is a bend, but I think it's not more than 45 degrees. That's okay, and there was no calcium visible here. Yeah, regarding wiring strategy, the first thing what we have to address is ambiguous cap. So that can be addressed with IVUS guided cap puncture. So for doing IVUS, out of these three branches, the diagonal is the best suitable branch for IVUS guided cap puncture, and the septals are much smaller, may not allow IVUS guided cap puncture as the depth of the vessel is quite small. Next thing, once we do a cap puncture with IVUS, and you can advance wire, and most important is your distal vessel is quite well visible, so it guides you pretty well in advancing antegrade wire after escalation. But the wire should enter into distal true lumen proximal to the D2. So you have a D2 just beyond the distal cap, and you have D1 at the proximal cap. So wiring should always take consideration of these two side branches at proximal and distal cap. If wire, antegrade wire, after successful IVUS guided cap puncture, if the antegrade wire goes subintimally and comes back into true lumen beyond the D2, then we can use either supercross or reverse wire technique to wire diagonal, so that we can save flow into diagonal. So we can wire it with these techniques, and then we can just do a cutting balloon and split the flap and then stunt. Or otherwise, if you are not successful, we can also take a retrograde and rewire through the true lumen. If antegrade cap puncture failed, so obviously we end up in retrograde. So there is a good retrograde septal collateral. So go retrograde, and you have a clear distal cap in the retrograde route, so you don't lose D2 anyway, and wire it. But most important is when you went retrograde, so puncturing proximal cap is very, very important. You have to do that in such a way that you won't lose D1. That's a care which we have to take. So for that reason, what we do is wire it retrograde till the proximal cap and come with antigrade wire using retrograde wire as a marker, then do a reverse cut beyond the diagonal, so that makes sure that you are not going to lose D1. So this is the care which we have to take when you go retrograde. So in antigrade, mindful of both side branches, that is entry point as well as exit point. In retrograde, since the distal cap is clear, so proximal side branch, that is D1, has to be operator should be very mindful in saving the D1. That's why you have to plan a proper reverse cut strategy. So these are the challenges and solutions which I already discussed. Yeah, and we went ahead and did IVUS of proximal cap from the diagonal, as I mentioned before. So this is how it looked. So this is the diagonal, and this is, we are coming proximally, and you can see here this is a septal. So the branch, as I told you, there is a trifurcation point. This is a septal, and this is the LED main vessel, which is coming just around the septal. So since it is a trifurcation, the visibility of main vessel was not that great, and this is what is LED, and this is the proximal cap, where we have to enter. So, and this is the proximal LED, and this is LCX. So I tried puncturing with Gaia 2 first, since there was not much of angulation, but unfortunately I was not able to penetrate. Then I went ahead and punctured with Conquest 12. So Conquest 12 couldn't perforate proximal cap, couldn't perforate, and in fact we had a problem. So you can see here, so there is a lot of contrast extravasation happening around. So that says, I think clearly there is a perforation happened. Since it is only wire induced, nothing will happen as long as you don't advance your microcatheter. So that's when we decided, either you have to confirm your proximal cap again, or just go retrograde and finish the procedure. So I decided to go ahead with retrograde, since the visibility of proximal cap is not that great due to almost like a trifurcation point at the proximal cap. Yeah, so yes, I went retrograde through a good interventional septal collateral. You can see this is a good interventional septal collateral present, and you can see as there is sound from JR retrograde, so I had to take an extra support by introducing guideliner. That is very important. Then only we can get through the septal with microcatheter. So this is what we did. So wiring retrograde vessel, again, it's very important because there is a stent at aortosteal area. So your wire should go through the center of the stent. If it goes through the strut, it will trouble you while advancing through the septal. So that's one care which I have to take. And you can take a guide extension. If the guide extension is just going over the wire, that means you are at the center of the stent. That also confirms that's what we did in this case. And also guide extension gives an extra backup to your retrograde gear and makes your microcatheter travel across the septal much easier. So yeah, this is a guide extension, and you can see we crossed septal quite easily with the CO03. This is a CO03. You can see, within a few seconds, in 10 seconds, we got through the septal into the LED. Yeah, this is how we reached LED. And once in LED, this Corsair was not getting advanced across this point. I dilated with a 1 mm balloon and tried advancing Corsair again, but it didn't advance. One of the reasons why it couldn't advance is it is not a Corsair Pro XS, it is only plain Corsair Pro, where the tip stiffness is slightly more, and there is a loop in the septal collateral here. So we switched to my fine cross, since that was available in that lab. So fine cross could cross across the this loop and went into LED. You can see fine cross is in LED. And yeah, I confirmed my distal cap. You can see there is a clear distal cap now, so there is no ambiguity. So then did a retrograde wire escalation. This is Gaia 2. Gaia 2 was advanced, and now we can clearly see the Gaia 2 is coming over this branch, so which is most likely the LED. So the suspicion of trifurcation and a second septal sitting at the proximal cap. Actually, that second septal, which I thought is LED, it's not a simple septal. So it's a continuation of LED, and there was a septal coming just beyond the proximal cap. Anyway, so since visualization from diagonal is not going to help in this case, I had to switch my antegrade wire into this LED and septal to look to view retrograde wire location. So that's what you can see here. The wire is into the septal through that LED, and now IVUS is just getting into that part of the LED. So once we can also see in two views how this was a diagonal where we did first IVUS, and this is where we thought it's a proximal cap, but when we see the course of the vessel, so it's completely away from what I thought before. So that's a problem, when you have multiple branches at the proximal cap, sometimes it really confuses you. So, and that's a cause for even perforation as well. So this wire we advanced, and this is where is a continuation of LED is, it's almost close to the diagonal. Now I did an IVUS from LED to understand the course of the wire. So retrograde wire, you can see this is a wire and this is diagonal. So you can see the wire is subintimal, so it has not entered true lumen. So throughout the wire is subintimal. This is almost like proximal LED, and this is the LCX which is joining. So it's a subintimal wire. So we can't advance this wire. You can see here this is subintimal. It's subintimal here, and this is a diagonal. So if I do a reverse card proximal to this point, we end up in shifting this onto diagonal. That is, the flap will close the diagonal. So we have to enter into the proximal LED after the diagonal. So that's a principle of reverse cart in this case. So you can still see the wire is subintimal in the ostial LED. This is almost close to ostial LED, and this is at the LCX. So the wire is just beyond the ostial LED, but it's subintimal all through. So that's when I decided to go ahead with a reverse cart beyond the diagonal. We took a size of the vessel, so it's almost like 3-point. So we can take a 3 mm and do a conventional reverse cart, and you can go through this article of me wherein we formulated certain principles in ambiguous cap CTO, how to choose side of the reverse cart to not to lose side branches at the proximal cap. And this is the principle basically. This is LMCA kind of thing, but this applies to every bifurcation. So either LED D1 or LCX OM or RCA, PDA, and PL. So any bifurcation you can apply same rule. So once you did a wiring, yeah, I was getting cap puncture, and then you came with a retrograde wire, let's see, or it just directly came with retrograde wire. So what you have to do is, when you're doing reverse cut, so do reverse cut beyond the ostium of the branch, and take a balloon beyond, and don't come with your retrograde wire up to the ostium, the proximal cap. So you have to always stay away from the proximal cap. So direct this wire towards the like end of the balloon. So it's an end balloon technique, and avoid coming beyond this point to minimize injury to this area, so that you don't lose side branch. So this is the care which we have to take. So, and with these principles, this is the area where I have to do a reverse cut. So I took a 3 mm balloon, took into the LED and beyond the supposed proximal cap, which we thought, and directed retrograde Gaia 2 onto the end of the balloon. And yeah, once the wire is in the proximal vessel, again we have to confirm the wire with IVUS, the wire location in relation to the side branches. So this is a retrograde Gaia 2, which is in true lumen in LED. And next you can see this is a diagonal. The wire is already in true lumen, so beyond the diagonal, and you can see this is a wire, and this is a proximal LED, and this is at LCX. So wire is in true lumen throughout the vessel, and especially at the location of all the side branches. So we confirm that, and then you have to go ahead with the next step, that is externalization, usually in retrograde. But in this case, as there is a stunt sitting at aortoosteal region of retrograde vessel, so it may not be prudent to do externalization. So avoid externalization and just do a tip in for a quick antegrade access. This is what we are doing. This is a Gaia 2, and this is antegrade fine cross. So we just did a tip in and pushed fine cross over the Gaia 2. You can see here. So now the wire is into fine cross, and now fine cross goes over the Gaia 2. Yes. So we did a tip in, and then advance microcatheter over that wire, and remove your retrograde gear and check your collateral. It's fine. And now you go ahead and do your intervention. So, and you can also take another step to increase your safety. You can do even IVUS from LCX to make sure that the wire is location is correct. That's what I was doing. So you can see this is the IVUS. Even LCX there is a lesion, so we decided we have to address. You can see this is a wire from LED. It's quite in true lumen, so that makes sure that you're not going to lose LCX. So since LCX is diseased, we decided to go ahead with even 2-stent strategy. I think this is IVUS from LCX, just reiterating same points, and we pre-dilated LED, and then again we did an IVUS. So this is a diagonal, so which is coming from the same lumen. So we confirmed that all the branches are coming from the same lumen, and then we went ahead with subsequent stenting with 2-stent strategy. This is 348 and 2.7528, and we just deployed LCX, then removed, and then deployed LED and did part in LMCA, and then recrossed and did kissing, and final report. And this is a final angiogram. You can see it's nice vessels, and you can see both diagonal 1, diagonal 2 are perfectly normal, and we can also appreciate overall expansion is quite good. And I was showed good lumen areas. This is the LCX, Austral LCX, which is almost like 5.9, and this is Austral LID, which is 8.7, and this is LMCA, which is nearly 13 mm square. So and we also checked IVUS of RCA stent, which is important. As I told you, just you can review this article to understand certain principles of reverse cart in ambiguous cap scenario. Learnings from this case is ambiguous cap with multiple side branches would complicate IVUS guided cap puncture. Retrograde in ambiguous cap without IVUS guided cap puncture. Plan reverse cart preserving side branch. That's important. Confirm retrograde wire cords at side branches with IVUS before aggressive predilatation. Avoid externalization if retrograde vessel has aortoosteal stent. Thank you. You can subscribe to my channel to see more and more such educational cases.